we have available for these measures. And then the last box up here is a denominator count filter. So we just have this set to 30 so that we don't have small denominators anywhere displaying on this page. So those are sort of all of the options you have to change and select how the data is being shown and displayed. Now we can kind of go through the bar chart down here. So on the left side, we have the measure name. So this first measure here is child and adolescent WellCare visits. Since we have these broken out by member race ethnicity, we can see all of those bars with our different members race ethnicity categories. The number, they're sorted. So they're sorted from lowest percentage to highest percentage for each measure as we scroll down. And then that white number is showing that race ethnicity categories measure performance percentage. The three vertical lines, we have three reference lines for the measures on this dashboard. So the dark gray or black line is state performance. And so that's our HCPF department performance. So for child and adolescent WellCare visits, for the department, almost 40% of kids had a well visit. We can also see in green, we have the RAISE overall performance. So for this performance period, Ray 1, who we have selected, so they're performing at 41.4% of kids getting well visits. And then the last reference line is this dashed orange line, and this is the 2021 NCQA HEDIS mean. So I think almost all of the measures in here are NCQA HEDIS measures. So we have that national mean there just as an additional reference point. So you can kind of quickly like see if we're looking at this, we're looking at Ray 1, we can see that they're performing above our HCPF department performance, but below that NCQA HEDIS mean for this time period. So that's sort of how you would read this chart. So let me just scroll down a little bit here. We can kind of see the different measures. So we have this child immunization status measure. And this is the combo measure. So it's like if the child had received all of those vaccinations. And so here we would read this as Ray 1's overall performance is 33.3%. It is below the state performance, as well as the NCQA HEDIS mean. And then you can see that the race ethnicity categories of Hispanic, Latino, and Asian are performing above the RAISE overall performance. And then you can see the other 5 groups performing below. So you can kind of also see how each of those categories compares within the RAISE like overall performance. Then we have 4 of these follow-up measures. First, we have ones for a follow-up after an ED visit for mental illness, and then we have follow-up after a hospital visit for mental illness. And for each of those, we have both a 7-day and a 30-day follow-up measure. And so you can you might notice that we have less race ethnicity groups for these measures. That's likely coming from that denominator count. So they're likely just we're not over 30 members. So you might see different groupings as you scroll through each measure since they have different criteria. And then we have our 2 combo measures for immunizations for adolescents. And then, I did want to also point out, if you hover over the bar, you can get the specific denominator and numerator counts as well. We have our postpartum care measure, And then our last two on here right now are our well child visit in the first 30 months. There are a few other measures that are in the health equity plan that haven't been incorporated in the dashboard yet, but that we're working on incorporating. I believe those are the COVID booster rate and screening for depression and follow-up plan. So like, let me show you if we pull that member age in. So then we can see we'll have our different age group breakouts. And again, like the bars will always be sorted by performance percentage. So here you can see, you know, these older age groups are actually pretty low performing. And then for 3 to 4 and 5 year olds, they're a bit above that, right? Overall performance. Let's see what else. We can just kind of jump through our different categories here. It gets a little crowded as we get to categories that only have 2 breakouts. So as example, member gender on here, we would only have them broken up by male, female, and still see it sort of all those reference lines, but they're a little harder. We have member language, which a lot of these come in as English and Spanish. And I think, again, there would be a broader amount without this denominator count filter. So just always kind of keep that in mind. And then we would have member county, and these lists can get quite large. So, you know, I'm not going to stop on anything for too long, but just kind of want to display the functionality and how we can look at all of these things. And then we do have member disability status. And then, like I mentioned before, we can go through and look at each region. So look at each region's data. So yeah, I mean, I think that's really a pretty good like overview of the dashboard and what it can do. There's a ton of data in it, so I don't, you know, we can't look at every specific data point, but I think I've really hit on everything that we have in here right now. We're planning to add in an option to look at right 8 as well as like all of the arrays at once, and members who are not assigned to array. So that is all planned to be added in still. Yeah, I think that's kind of all I have. I would, if there's any questions, or if Aaron, you have anything to add or anything you want to look at specifically in here, we can.
Yeah, this is really great. Thank you, Allison, so much. I know we're constantly retooling and adding to it. Our goal is to ultimately have some type of public facing dashboard on our website. So this has too much PHI on it, so we would not share all of the intricacies of this dashboard. But we will definitely make sure that when we are in a good space, that there's going to be some type of data on our website. So again, this is just a snapshot of the capabilities of the dashboard. We're really excited. Our next phase is to make sure that our arrays have access to their data sets. So that way they can start to plan out their health equity plans, which are due to us on the 31st of December. So I will stop there. And I think there's a question for Allison from Marius. What is the adolescent combo 1?
Let me see if I can find that real quick. I don't know offhand. The measure comes to us with that title, so it's that HEDIS one. So if you have access to that, you should be able to find that. Do you want me to look that up right now, Marius, or do you want to take a look at that yourself?
Can you just scroll down a tiny bit? Because
Oh, yes.
so the HEDIS is adolescent combo 2. And then do you have the HEDIS combo 10 for children, or is that what that's referencing?
Yes, we do have the combo 10 for children. It's just, it comes in as childhood immunization status, so
Right.
it's up here.
That's interesting. Will you send that to me later if you find it?
The
The
like,
combo one. What's
yeah,
in combo
I can
one?
send you the document that would like lay out which specific vaccines are in there. Yeah.
Okay, cool. Thanks.
Yeah. Okay. Let's see, is there another question? Sarah, I think Karen touched a little bit on that question. I think right now it's not, this dashboard isn't accessible to the raise right now. And then Clara, the dashboard also includes behavioral health and COVID data. Yes, by behavioral health, I'm assuming maybe you're meaning like our encounter data. So our tool that calculates these measures does is starting to incorporate that encounter data into its calculation. I'm not sure what you mean by the COVID data. Could you clarify that?
Yeah, sorry. So 2 things. One, I'm asking about the metrics that are included in the template for the raise for the plan. So all those metrics that were included in the template are included in this dashboard. And we received data back in February. And when we received the data, we received the metrics for prevention, for maternity, but we didn't receive COVID or behavioral health data. But now that you have this dashboard, I was curious if any of those metrics were included in the dashboard for COVID and behavioral health.
Yeah, so the behavioral health ones are here now, and we have just finished like prepping the data set that's going to be delivered to the raise, and so that will include these behavioral health measure data set. The COVID vaccination measure isn't yet, that's not in the dashboard yet. And so this is actually more updated data than what was sent in February. But the updated data sets for each ray are prepped, and then so those will be getting sent out soon.
So what is the time frame of this data?
So this is calendar year 2022.
Okay. Thank you.
Yeah, you're welcome.
And Allison, I see we have a raised
Oh.
hand. I can't see who it is right now, but.
Hi, Allison. Hi, Dana.
Hi.
Oh,
You know, this is Dawn from Colorado Access. Thanks so much for sharing the dashboard. It looks awesome and it's excellent work. I had a clarification question for the health equity plan that Aaron had mentioned. Is it expected to use calendar year 2022 as is displayed here as the baseline for that plan, or calendar year 2023? And if so, the plan would be due, before the entire year of 2023 is available.
Great question. So I'm actually working with Helen Desta and Nicole Nyberg on the baseline. So right now we have 2022 data. And so we want to make sure that when we get the data to the raise that they're using the most informed data. Our goal is to really have rolling data where we can actually provide the most updated. So our baseline right now will most likely be calendar year 22. And then once we get 2023, then we'll move forward with that. But for now, my first thought would be for 2022 as far as the baseline.
Thank you.
Okay, I'm not seeing any more questions, so if there are any more, speak now. Otherwise, yeah, thanks for letting me share this. Yeah,
thank
I guess
you,
that's
Allison.
it. Okay, yeah, thank you.
If any other questions come up later, we can make sure we can get them to Allison and get you some responses if, you know, throughout your work group discussions, something comes up. Just make sure to note them and we'll make sure to get a response to you. So we should, having mouse issues today, but we should see the screen, right? Everybody still sees the slides, I'm hoping.
No, right now I haven't shared them yet.
Okay.
Because I think it's my turn, right?
Yep, it's your turn. I'm sending it over to Jose.
Okay. So let me start my screen. No. Too many screens, sorry. Oh, okay. So I hope everybody seeing my screen. Yeah, I think so. So I have been asked to speak about health equity and health access as it pertains to accessibility as a whole. And by the way, I want to thank Fong for helping me make the presentation. Thank you, Fong. You were awesome. So we're going to focus on priority 5, which is accessibility, as I mentioned earlier. And with the understanding that accessibility encumbers so much that we try to keep it shorter, since we have a limited time to present. But of course, afterwards, I'm open for more questions if they come up. And later, if you have them, you can also reach out to me. So priority 5, increasing all forms of accessibility to healthcare services and coverage. And please let me know if I'm speaking too fast, interpreters. CMS has a responsibility to ensure that individuals and families can access healthcare services. In Colorado, we are grateful to have a very robust accessibility measure, but there, of course, are opportunities to increase and develop accessibility more, and the understanding of what accessibility is and means. So, of course, I'm not going to read the slides to you. You know, you can read them, but I'm going to do touching some of the points that we developed. So, healthcare accessibility is defined. How do we define accessibility? Especially in the healthcare arena. So, the accessibility in the healthcare space refers to the ability of individuals with different abilities to have coverage, access and use healthcare services and facilities, including physical spaces, information, communication, technology, and social and cultural activities, which is, so all of these categories are what we are going to dive into a little more. So starting with physical accessibility, which obviously is I guess the easiest for someone, for us who work in the field all the time, because so I'm going to present that in current state, what could be the improved and what should be in the future, our vision or outcome. Accessibility, public transportation, for example, so that people can move around and access their own healthcare and remain healthy, because we also know that being able to get out into the community keeps people with disabilities and everybody really healthier. Access sidewalks, general accessibility healthcare facilities, like for example, buildings nowadays are built from the ground up and from the get-go accessible. Of course, there's a lot more, and there's a lot of minutia in this. For example, in a dental clinic, the dentist has a chair that is removable or permits the access of someone who has physical impairments, things like that. And continuous improvement or opportunities, we can break it down to a few that are especially important, especially specialty facilities, example dental. So that's what I was saying. Currently, while we do have buildings that are accessible and dentists that have accessible buildings, they don't always understand what accessibility really means. Rural transportation, that's a big one. For people with disabilities, rural transportation is very limited, and as well as rural cities accessibility and rural clinics are only semi-accessible. So also the last part is really important. When one gets training as someone with a disability, while it is okay to, let me put it this way, it's okay to treat us the same way for equality. Equality doesn't equal equity always. So accessibility for someone with cognitive or developmental disabilities needs to be accessible for them. So the vision or the outcome that we would like to see in the future is good accessibility regardless of geography and regardless of disability as well, even though we didn't write down that one. Because different disabilities require different accessibility. So financial accessibility, that's a big one, right? Who doesn't know that everything is so expensive and that if you don't have health insurance, you cannot afford certain things, you don't have this or that. There are so many things. So current state, Medicaid and Medicaid buying covers medical and home and community-based services, for example, attendance to medical equipment. That's perfect, or almost perfect in Colorado. And we are so proud of that. Because those are, in fact, CMS calls that Colorado's crown jewel. For example, CDAS. Exchange, we have been very successful at making people, giving people access to the exchange, people who need it that way. And also, we created that last year on MiSalud for individuals who are undocumented to be able to access something similar to the exchange that is meant for undocumented folks. So, and currently we have 10,000 places for people who need it for very low cost or almost free with no premiums. Continuous improvements. Medicare and private insurance do not cover home and community-based services, only purely medical. On DME only covers if a facility or homebound expand. So homebound, right? Expand coverage. We need to expand coverage because if you guys remember back in I think it was 3 years ago, when Biden won the elections, there were candidates that were saying Medicare for all. Well, we told him no, it's Medicaid for all because Medicare does not cover people, only adults who are older than 65 years old or people who have no disability, who have no disabilities and are super low income, or people with disabilities who are homebound. If they are not homebound, they're not covered by Medicare. And because this is federal, this means that we are lucky in Colorado, but the other states are out of luck. Medicaid buying ends at 450% above poverty level. Ideally, we would like to see that limit expanded in the future, because of course, as the years advance and the economy changes, all of a sudden, 450 might not be enough. Plus, there are other opportunities now because of the ADA being 25 and 32 years old, people with disabilities are expecting to have better opportunities to work. And therefore, 450% all of a sudden seems limited for someone who wants to take maybe a higher end job, for example. So our vision, of course, universal healthcare. Who doesn't want that? Who of us? I mean, there are people who might not, but we do. Not having a poverty level limit for individuals living with temporary or permanent disabilities, so that we are never forced into the position of having to spend down anything we have or quit our jobs because it's too higher end pay. The next point is information and communication. Obviously, that's super important in this age. Website, documents, large print are the current states. We do provide these things. And of course, to a certain degree, and that's what we are here to talk about. Software, text to speech. So technology, for example, is allowing us to give or provide this type of accessibilities. Exactly. Thank you, Dana. Exactly. So audible books, for example, are a big one for people who need to hear instead of read a book, or simply understand better by listening than by reading. Virtual meetings platforms have given a great way to participate in important stuff to people with disabilities. And language. So, for example, right now we are providing language interpretation and ASL. So not just the spoken language, but also the language of other people with different types of disabilities. Real-time access to real-time translation and other assistive technologies that allow us to communicate better and to also learn better. The things that could be improved: file standards in GUIs programs, IEP rules, for example, so that right now certain school districts have their own rules and follow their own rules. They don't necessarily always follow standardized rules that apply to all school districts, which in my experience, and TCDC and the Grupo Vida has seen this, has limited kids' access to real accessible education for them, or that works for them. Using plain language is another example. When we talk about healthcare and healthcare materials, we use a lot of jargon. We're used to it. The ones who work like us in the field, we're used to it, but that doesn't mean that everybody understands. So that could be improved. And I know HICPOP has been doing a great job at implementing plain language, for example, but not every department and every agency of the state is doing so at the same level. Clarity and simplicity in healthcare information and communication will be our first point for our vision, what we would like to see in the future. In language and modality of person preference. So, for example, if I speak another language, or if I require a cell, or if I require large print, like we said in the beginning, those are examples of better communication. Different colors for people who are colorblind, for example, is another thing that is really important. And in this, there's a lot more, of course, but those are the points that we thought were really important. Cognitive and sensory accessibility. This is often missed by agencies, by providers, by corporations, etc. Right now, state agencies are in the process of implementing use of plain language, right? So as we mentioned before, in communication, it also applies, of course it applies in cognitive and sensory accessibility. So for example, using the plain language for public benefit rules, policies and public meetings, so that more people can access this information and can advocate for themselves and be more empowered by that fact. Current guidelines support increased cognitive accessibility in healthcare, and that actually works really well. But all of these 2 points are working really well. Of course, there's always room for improvement, but these are some things that are really working well for continuous improvement. Practice what the guidelines preach. So often the guidelines say one thing, but the practices show another thing. And that's why we say that. Clear and concise language, formatting and instructions. So for example, when presenting something in a meeting or when sending materials out to the community, make it in a clear language that is concise. So you can access the legal jargon and all that, but you have access to an alternative version, for example, that has a plain language explanation. Reduce jargon in technical terms is another thing. Large print symbols, color coding, that helps a lot. Depending on what we are talking about, sometimes changing a color for something or making it bigger or whatever, or using symbols to point out something helps a great deal in increasing accessibility. Accessing alternative ways to access information. So for example, when information is only available digitally, it hinders the ability for others to access that information, than others that may not have access to technology, for example. And that's just an example. Better teaching tools, the same point, right? So be able to adapt to different abilities and disabilities so that everybody is able to learn what teachers are teaching, what the state is teaching, etc. Personalized support one-on-one. That's a big one. For some specific populations, they require and prefer one-on-one help rather than sitting on a classroom and listening to the teacher. For example, I imagine this presentation will be very confusing for someone, for example, with certain types of autism. It will be very confusing. They will not understand anything I'm saying, even though I'm an expert in disabilities. I'm making this presentation for the state, and therefore I'm not making all the adaptabilities that I could be making. Assistive technology. So, for example, often we encounter that state agencies don't have enough accessibility in their website, for example, and that's something that could be improved. And we have asked, and there have been some efforts, but it's not yet what it should be. So for the future, everyone will be able to understand how to access benefits like the special education, mental health, employment, support, etc. So that's our vision. Government accessibility, and that's our last one. So I'm not sure how many of you have heard, but for example, every year when we have elections, CCDC releases a accessible guideline for the vote, for the ballots, I mean, and also how to use for people who are blind, for people who are disabled, where there are voting polls that are accessible. And that's kind of what we mean as well. So the current state, about 15 years ago, the Capitol was made accessible so that people with disabilities can participate in the democratic system. So now, for example, we all can access the Capitol. And if you have a disability, but you are a citizen lobbyist or representing an organization, you can access the floor. You can access all the committee rooms. They have different doors that are accessible. The floor has lifts that they have the legal obligation to give you access to and help you one-on-one. And that was made by a CCDC member who accomplished this. State agencies are required to accommodate people living with disabilities in every public meeting. So, for example, this meeting is accessible, right? We know, like, for example, Zoom is extremely accessible for people with disabilities, and also the use of ASL, language interpretation, and also captioning. So all of that is what we mean by accessibility. And since HICPO, for example, DORA also runs meetings that are super accessible. The city runs them really accessible. The city of Denver, I don't know other cities, but I have seen the city of Denver, and those are fantastic things that we have, and we should never walk away from. Finalizing, so for continuous improvement, finalizing the implementation of plain language use. So we are almost there, but we're not quite there. We need to keep at it. Right now, for example, there are many task forces that HICPO is leading or helping us lead, or we're helping them lead, more like, and yet some of the rules that are being presented and some of the data that's being presented is not yet quite there in plain language for everybody to understand. Authentically gaining the voice of community members living with disabilities. So in many cases, and this is a very controversial one, so I'm sorry, but many times there are meetings that you feel, you come to the meeting and you feel like you're being included as a person with disabilities just to check a point, just to check a little checkbox that says, yeah, I talk to people with disabilities, but you didn't really listen. Because at the end of the day, you didn't change anything we told them to change. So we would like to see, of course, and Aaron, thank you, because you are an example of what I am saying right now, is actually implementing and listening to people with disabilities, because we have stuff to say, and since 2020, especially with the pandemic, we proved that even Governor Polis, amazing Governor Polis, hired someone with a disability to run the disability office for the governor, because he had important stuff to say, because he designed Medicaid buying for Colorado, and because he's so smart that he brings us into different tables, because they know that we adapt fast, that we are used to being poor, that we are used to financial and health hardship, So our opinion should matter. And that's one of the points that's why we say that. So our vision for the future, all policies and rules are focused on serving everyone, including people with disabilities. And we say including people with disabilities, but I want to make this point clear. When you make something accessible for someone with a disability, in fact, you're making it accessible for everyone. So I'll give you an example. In my building, my apartment building has an accessible button for the main entrance. It has stairs, but it also has 2 ramps in each side, one in each side. And I've seen moms, I've seen elderly people, I've seen people without any disability who are completely able-bodied use them. Why? Because they come with a big cart of shopping stuff, groceries or whatever, and they cannot free their hands enough to open the door. They push the accessible button with their hip or with their arm or whatever, or even sometimes with their cart, because at the same time they're carrying a baby. So how are they going to open a door that is 15 pounds heavy without that button? So when you design something that follows universal design for people with disabilities, you're in fact helping everyone. So, and that's true for everyone, for everything, for policies, for Medicaid services, for other services that serve people with disabilities. They also help other populations in general. Like, oh, this is not mine, right? Oh, no, this is our last point. So we should please discuss strategies, tactics, ideas to increase accessibility in healthcare services and coverage, to address all these points that we mentioned. And if you guys have any questions, I'm not sure how we're doing in time, Dana.
I think we are good on time. So I think based on this slide for our work groups, in your work groups, and I'll send the link to all of the, let me do that right now, to all of the work groups and the drives, and it'll have a Jamboard for each work group. And so for today's session, we ask that you discuss your top tactics or your ideas to sustainably increase all forms of accessibility to healthcare services and coverage. So select one or more accessibility category in your discussion. So the physical, the financial, the information and communication, cognitive and sensory, or government, and incorporate that into what you've already been working on, and begin to start formalizing your recommendations that you will make to the department. Start working on, the number of recommendations that you want to present from your work group to the department, and just include one of the disability, the accessibility actions that Jose just discussed. So we can start doing that, and there's going to be 4 breakout rooms: the maternity, prevention, behavioral health, and access to care, the vaccinations and COVID group will stay in the main room, and we will have our interpreter stay in that room as well. If anyone needs interpretation services, they will stay in the main room and be with the vaccination and COVID-19 group. All others, I'll open the rooms now So you can select your room and you guys can get to work. So you should have the Jamboard link, and you should have a link to the Word document that was used, I think right around the first or second session. So I'm opening the rooms now. So feel free to choose your room. And on the Jamboard, it has the instructions that were listed on the slide that's shown here. So you'll have the information on your Jamboard to begin your discussions. And we have 30 minutes for work groups. And again, the vaccination and COVID group will stay in the main room.
I'm on the phone. This is Julissa, so I'm gonna stay with the vaccine group here, right?
Yes, stay in the main room,
Oh.
Julissa. Yep,
Okay, thank you.
thank you.
So how do we go to the other groups? I'm sorry, I don't see
You
where.
should see a thing on the slide that says breakout rooms. You might have to hit the eclipse on the side where it says more. And if you click on there, it should give you a link to the breakout
Oh,
room.
okay. Yes, thank you.
Okay, you're welcome. So everyone that's on now, are you intending to stay in the vaccinations and COVID work group? All right, and I will leave it to you all to begin your discussion. I'll be popping around all the other rooms, but I'll leave it for you guys to begin discussions.
So do we want to just all independently work on the Jamboard and then have a discussion, or do we want to have a discussion first? What are you all thinking?
Discussion, my friend, because I'm over the phone.
Yeah, I don't have a link to the Jamboard, so if you need us to get on there, can you resend that?
Yeah, I just put it in the chat. Well, I just chatted it to everyone.
Sophia, can we do a discussion since I'm over the phone?
Yeah, totally. And I'd love to hear from others too on if anyone wants to lead the discussion today. Whatever y'all are thinking. So Lisa, what we're looking at right now is the Jamboard has, so for CMS Priority 5, which is increasing forms of accessibility to healthcare services and coverage. The discussion would really be around our top tactics or ideas to sustainably increase accessibility to healthcare services and coverage among different categories. So the categories would be physical accessibility, financial accessibility, information and communication accessibility, cognitive and sensory accessibility, and government accessibility.
Okay, got it. But will somebody else will want to speak, Sophia, because you and I have been leading this group, so maybe we'll give the floor to somebody else.
Yeah, I think if someone else is interested in leading the discussion, that's great. And then for anyone on the phone, I'm happy to put in the sticky notes if you have ideas that you want to chime in on as well. And was everyone able to access the Jamboard link that I put in the chat? Can we maybe take attendance of who's participating? I just want to make sure that we know who's actually in the room right now since we can't see anyone. Can you thumbs up if you're participating in the discussion today? And this is the vaccination work group.
Thumbs up.
Thanks, Kaylan. Thanks, Lisa. So it looks like some people might be away. Oh, okay, cool. Heather, Jason, Abasi. Awesome.
So are you guys doing the Jamboard or nobody's talking?
I'm getting an error when trying to access the Jamboard. And it's asking me to end the session, and I don't want to do that. I don't want to disconnect it or something.
Yeah.
I am able to access the Jamboard, but happy to have a discussion instead if that's more. If we can all do that better as a group.
Sure, I think, yeah, that makes sense. And then other folks, please feel free to chime in or put your information in the Jamboard. I guess from CCHA's perspective, as I'm thinking through some of this, so we are one of the RAIs. And I think some of the work that we've done kind of translates into several different communities. But when looking at just increasing overall accessibility, I guess, to vaccinations, I really think, you know, Julissa, I'm looking at a lot of your best practices and the work you've done in terms of going to the community rather than requiring people to show up at a doctor's office or a pharmacy or a public health office that, you know, might be difficult for them to access. So I'm thinking like just continuing with these efforts focused on going into the community. And I know that CDPHE, their vaccine bus recently, they stopped the larger bus, but they are offering smaller vans that are going to certain, I think, rural communities mostly. But I think that's a best practice, you know, in making sure to go to these locations where people might already be accessing other services. So that's one thing that comes to mind for me, at least. Anyone else?
Can you hear me, Sophia?
Yes.
I really echo what you said. Meeting people where they're at, that's the solution to it. That's one of the solutions to accessing care and vaccines, you know? And I really feel that showing up at churches, mercados, or grocery stores and schools, it will always be the key to success.
Hi, this is Jason from Denver Health. I'll echo the same. And one of our strength is the mobile clinic. And we have, like, for example, from last month, at least 13 of them, 13 events during the month. So those clinics, call it bus or mobile clinics, they stop in a specific location, like you said, like close to a supermarket, some events, during the summer. And Denver Health looks at vaccine uptake by zip code and determine the percentage of members living in zip codes who have received COVID vaccine and or booster. So those mobile vaccination clinic can be deployed to the communities and with a high unvaccinated rate, in a way or effort to boost those numbers.
But, and Jason, I'm gonna add a little bit to what you're saying. Denver Health, have their mobile clinics, but it's not only meeting people where they're at, but it's also approaching people where they're at and talking to them and educating them and building that trust. Because I get the numbers from the mobile clinic at Denver Health last month and the months before, 0. You guys have seen 0 people on your mobile clinics, which is pretty sad, right? Because of the good services that you provide. But that tells me that it's not only meeting people where they're at, but also validating the cultures of the community we're going to. Not because we show up with a big mobile van, or not because CDPHE is gonna show up with vaccines. And you have to have those leaders that mobilize vaccines in order to have access. Would you agree with me, Jason?
I do.
Okay, gracias.
Thank you.
So I don't know, Sophia, if you're making notes of what we're saying, but it's not only meeting people where they're at, right? But it's also validating their cultures and talking to them, letting them know that we're coming.
Well, Lisa, and Sophia, you can redirect me if I'm gonna ask a question that leads us in a direction you don't want to go, but I completely agree with what is being said in some of these efforts that are, of course, community-led, like focused on community trust, building relationships. How have you seen success in some of more of the rural areas where, again, we wish that going to PCP offices could bridge the trust, could be in the community, could help folks get access to vaccinations and needed care, well visits, et cetera, have a lot of education-based relationships. How have you helped hold providers accountable when there's real difficult
to work with?
Yeah, when there's real difficulty.
Yeah, they're really difficult to work.
I could talk about multiple examples of that, but again, I agree with you that the work needs to be done in mercados and schools, in community events, but also when the provider is there, is open, is one of the only access points in some rural communities. How do you help hold them accountable?
And my friend, when I work in rural communities, like in the end of August, I'm gonna be in Grant County, working in Granby. My outreach is to the churches first. I'm part of the Colorado Catholic Conference, and that helps a whole lot because the priests know by firsthand that I'm a Catholic, number one. And number two, it's educating them about their public health system, because just some providers are very difficult to work with. And the health departments in those small areas are a lot nicer than other providers. So it's not the perfect scenario, but that's what we are working with. So I will be working with the churches. The churches will be charged talking to the community about the services that public health departments offer, because usually we don't know what public health departments offer. We think about a public health department like a government identity, so we don't want to go there. We don't know that they have an STI testing clinic. We don't know that they have WIC. We don't know that they have vaccines. We don't know that they have many other classes, right? So my job as a cultural broker, when I go to those rural areas, is to build the trust first at the church, because that's where my community gather. Between 72 to almost 80%, I'm sorry, almost 80% of the Latinos here in Colorado are Catholic. So that helps a whole lot, but I'm with you. I just don't know how to work with difficult providers. I just find ways of who wants to work with my community and treat them with respect and dignity, you know?
Yeah, I completely understand. I wish there was some systematic accountability or some best practices around that, that we could help really.
No,
improve
nobody's
those
holding.
practices.
Yeah, nobody's holding providers accountable, and that's why they continue doing what they're doing, my friend, because nobody holds them accountable. And that's super upsetting to me, because providers can say, no, we can see you. You don't have medical. Okay, we cannot see you. What about the underserved? And I feel, and you correct me, Sophia, that that's the job of the RAIs to hold those providers accountable. But I feel that the RAIs are also, they cannot cross the thin line. Or who's holding the providers accountable, Sophia?
I mean, I think that's kind of a loaded question. Yeah, I would agree that the RAIs in partnership with HICCUF and others, I mean, we certainly, when we partner with our providers, we have like a provider incentive program, for example, where we incentivize them for certain actions. A lot of it, I think recently has been more related to our key performance indicators and really just helping increase well visits, for example. But I think this is a really good conversation and point, Kate, and especially Kaylin, I'm glad that you brought that up around like, how do we hold providers accountable, especially if, I think it's important that we have community leaders that are out there, but I think it's one of those things where we need to have everyone at the table. And also like when looking at accessibility, I know one thing that we help members with, and I'm sure other RAIs do too, is we keep lists of providers that have certain accessibility, meet certain accessibility needs. So for example, if someone is in a wheelchair and needs to access a provider, we have a list of providers who have scales that can accommodate that. And so I don't know if I'm necessarily answering the question, but I do think it's a good one. And then Abasi, I think you were trying to chime in.
Oh, no, great discussion. And I'm actually, I have a bit of a question that I don't know the answer to. So we were talking a few minutes ago about culturally competent care and meeting people where they are, right? And what is that messaging? Well, that's almost a problem and a solution in my mind, because the one thing that people are looking for is consistency in messaging, right? But when you're looking at culturally competent care, that message can be tailored just a little bit to the audience that you're speaking to. And that's where the big area of mistrust comes in, right? So in my mind, as we sit back and talk about this, and I think it's a great discussion, is how do we solve that particular issue?
Oh gosh, my friend, that issue has been an issue for decades.
Yes,
so,
correct.
Correct. So we can start conversations, and I like to be called a disruptors, but sometimes, right? It depends who's calling me a disruptor. Because if you're calling me a disruptor to offend me, then I don't like it. I'm more like a public health advocate. But I am seeing a little bit of changes in that. But providers and health departments are pushing not to have that cultural competency part. They just
right.
they just want to be comfortable. They just want to go back to 2019. For them, working Monday through Friday is cool. No after-hour clinics, no working in the hood, no working with people of color, even though they're not going to tell you that. So that's why it was a good question when they say who's holding, when somebody said, and I'm sorry because I'm on the phone, okay? I don't see your names, but when they ask who's holding the provider accountable, and like you say, this is a problem, and how are we gonna solve this problem? How when you and I know, and we know really well, the providers are doing what they can just to survive too, you know, and say, okay, I'm doing my job, check and check and check. Right?
No, 100% agree. Yeah. No, your points that you brought up were 100% valid. 100% valid. I've just, like I said, as you were speaking so passionately, I started to think about culturally competent care in itself, and how do we deliver that, right? With a
Right.
consistent message, right? Because that's where I think the breakdown happens, because of the inconsistency in messaging.
Yeah, you're right. And you cannot see me, but I'm very passionate. Passionate about this topic. This is my cup of tea. And, you know, and even though I create lots of enemies on a daily basis, because I will say exactly how it is. For the longest time, my friend, we have been trained to be sugarcoat things or be nice because we can lose our jobs. Okay, for me, enough is enough. You know, we're gonna lose our jobs regardless. So in here, we need to hold health departments accountable. We need to hold people accountable, because our community keeps struggling accessing care. And you know, the health departments act like vaccines are a privilege and not a right. So it's our job to let them know that no, mijita, no, mi niño, this is not a privilege. This is my right.
Right. Correct.
I'm sorry, Sophia, I just went to my activism mode and lost it.
No, I think it's wonderful. I mean, like I said, I can hear the passion that you have around this. But no, great discussion. And like you said, I can't see people's names, so I wanted to call you by name, but I couldn't see your name from my phone.
My name is Julissa, like asking who and then Lisa, Julissa. Yes, and you tell me also, I have a question for you. How is it that in Colorado, we approve weed, okay, a drug? How is it that in Colorado, it's easy to get a weed card, but not a green card? How is it that we can approve weed, but we can legalize marijuana, but we cannot legalize immigrants? Come on, man, give me a break. And now with vaccines, I see it. I organize between 3 to 5 vaccine clinics a month, but I call them vaccine parties because I make them a party. And every month, my friend, I'm going on my 200 clinic where I offer COVID, flu, childhood vaccines, and I still see the struggles in brown and black communities. And you know, I have my contract with Ray 6 and 7 here with Sophia, and Sophia can testify in many ways how challenging it has been, because I know that many organizations have called them and say, you know, we don't want to work with Julissa. Why do you think they don't want to work with me? Because I get them to work, right? Or what do you think, Sophia?
Yeah, no, I always appreciate hearing your feedback, Julissa. And yeah, I think it's about really, you know, changing our quote unquote traditional strategies and seeing where we can break down those barriers, that misinformation and that mistrust. And, you know, sometimes I think it's difficult for some organizations to immediately get on board. And I think that's why we just continue to have these discussions. And I think, Julissa, it's been really helpful for you to have, you know, kind of those one-on-one meetings too, like you said, with churches and others, and just really having that face time to really deliver what the message is and kind of where you're seeing the disparities. I did have a question, and Kaylan, I also saw you off mute, so I'd love to hear from you too. But with today's topic being focused, I think a little bit on Medicaid members with disabilities. Julissa, I'm curious to hear from you and others, you know, on how some of your best practices and kind of what you're seeing among, Julissa, I know that you focus on Latinos and those with, so maybe Latinx members with disabilities, and kind of where if there's any best practices we can gain from that to kind of continue and increase that access, if that makes sense.
In my part, when I work with people with disabilities, Sophia, I'm gonna be honest with you. I don't ever wanna disrespect them because I can empathize their struggle, but never replicate their struggle. So what I do in the Latino community, I send them to Jose organization, to Centro Vida, I believe. And Jose does a very good job on dealing with his organization, right? Does a very good job helping that community. So on that, I'm a little bit short on that one because I just don't want to pretend to have a solution when I just don't understand that community specifically.
Yeah, that makes a lot of sense. And I respect that, you know, that you're kind of like, yeah, that's not my area of expertise. What I like though, is that you have, you know, that point of contact and that collaboration with individuals who do have that expertise. And so I think that's an important, I'm going to make a note of that on here somewhere. Just, you know, I think the potential for that increased collaboration of being able to say, I'm not the expert in that, but I know someone who is, and engaging more with those people who are experts, if that makes sense.
Yeah, I just feel that when you're not the expert, or you don't have someone in your home with disability or something that you can understand or relate to, I just feel that it's more like a slap in our face when somebody's trying to help us and they don't even get it. So I prefer to be honest and say, mija, I just don't understand your world and your life. I empathize with you, but I'm gonna get you to somebody that is gonna love you and care for you and your family, and they understand where you come from. And people really appreciate that. And that's what I always think, you know, when I see other communities coming to my community, I just smile, Sophia, because I'm like, how is it that you think you're gonna come to my community and replicate my struggle? I don't think so. What is the rest of the group thinks about that, or your feelings about that?
I agree that I don't have specific expertise in this area either. So Julissa, I appreciate what you said about that. And for those on the phone, I'm Kate. My name is Kaylin.
Kaylin, okay.
Yeah, and I work with Region 4, so HCI. So I'm on the Ray side, Julissa, and I'm even asking best practices of holding providers accountable, because we don't need to go into that whole spectrum here again, but there's so many factors that hold the status quo in place. About with members with disabilities, I'd say one of the things, speaking to some success stories I believe we've had in our region, you know, when some of the first rounds of vaccines came out, we really did an extended push to help vaccinate people in their homes. And I think that this goes back to what you were saying, even in, again, getting to know special communities, subpopulations, the people who live in the community, versus just sort of blankets of swaths of Medicaid members or whatnot. But there was some real success in me, again, surprise, meeting people where they are and offering these services in homes. And it's not that innovative to go to people who may have trouble accessing the system in other ways. And we don't need doctors to do that. We can get a lot of other staff to get out and do that. So I think that there has been a lot of, you know, that's not just members with disabilities. And I don't want to say all members who are housebound even necessarily have a disability, but I think that we saw a lot of success, at least in our work, when the vaccines first came out, and doing some of that work. And unfortunately, it's gone back to, you know, the status quo of you have to come in for care. I think some of those systems and processes have gone away, which is unfortunate that we haven't just learned what worked and then kept what's working and sifted out what hasn't worked. Sometimes we have trouble doing that, of course.
Yeah, thank you. I also made a
Yeah.
sticky because that was definitely one thing that we saw successful too. Is we were able to provide a list of members to our local public health agency, who then was able to go to people's homes and provide the vaccine. And it's a bummer that kind of went back to status quo. And I think it would be great if we can explore continuing to leverage our prior experience with that and what that could look like for people. And sorry, Kaylin, I was mispronouncing your name before, so I apologize for that.
That's all right. It's
We
hard.
all have kind of difficult names around here, so we're like,
Yeah, I was gonna say, it's always hard to read and say, so I try to speak to how you pronounce it, because
but you know, Kaylin, what are your ideas when it comes to holding providers accountable beside giving them an incentive?
well, it's interesting, Lisa, we had an incentive program. We did some, I don't know if they're calling all the group back, so maybe we could talk offline, but we did an incentive
Okay.
program in Region 4. We should talk about it. It was really interesting.
Can you email me? Because I have some questions for you.
Yeah, well, you put your email in the chat. I know I probably have it, but would you mind just doing that real quick? And I'll send it to you.
Sophia, can you do it for me, please?
Lisa, I
Because
can look it up. I can look it up.
yeah.
I forgot you were on the phone.
Yeah, I'm driving, my friend.
Okay, everyone, I think we're all back from our work groups. So now what we'll do is just kind of do a round robin of all the work groups and just hear from each group on some highlights of their discussion. And so I'll just randomly pick some. So we'll start with Access to Care group.
All right, Sarah, wanna take it on or fun? Since you guys were mostly active with me.
So for our Access to Care group, we kind of went through each accessibility kind of level, and then we kind of started to do some conglomeration of things. But we did talk about ADA, guidelines not being like the accepted meeting the bar. I think, yes, that's a requirement, but it definitely doesn't mean it's great. So access to care wise, you want it to be an approachable thing. You want it to feel like you don't have to still go and tackle some barriers because they just like baseline hit ADA. So I think talking about what's the gold standard for healthcare accessibility rather than ADA guidelines accessibility, especially even in exam rooms, in the vitals process, like anything that makes you feel like it's not built for you. Having options in how to interact with access care. So like having a broad design of ways that people can access care and don't have to actually either qualify a disability. It should be just accessible for all. Things that are made accessible for people with disabilities. That doesn't mean that you have to have that recognized disability in order to be able to use that accessibility tool. Having that as like available to all so that people can engage the way they want to, because access to care, some of it is just like feeling like it's approachable, feeling like it's made for you, and feeling like you can engage in the way that you want to engage. We did talk about a lot of the social determinants of health and having, access to that from a sense of like delivery and maybe collaborating onto that with other healthcare, tools. And also having ways to accommodate for technical access to care solutions like telehealth or using tablets and that kind of thing. It still can be very intimidating for others. And then a big thing was transportation. I think we all talked about how we need more like short-term last minute solutions that we can rely on for transportation to get access to care if it's only in person anyways. And just having choices and designing for people or personas that need more support but then not just giving it to them, giving it to, making it a choice for everybody. I don't know if anything else that I missed. I tried to really, really simplify it.
The only last thing is that we talk about how if the government, if the system is flexible and moldable, like the disability community is, for example, we will be in a better place, because the example I gave was that during the pandemic, we found out that telehealth was an extremely good idea, but it was never used to the point that it was used during the pandemic. And now, in some ways, it has been taken back because some people are saying we should go back to the in-person, all in-person. One, that is not doable for some people, or it's just easier for them to do it through telehealth, for example. And it should be allowed, right? It should be allowed to do it more easily. And with that comes other things like, anything that can make life easier, language interpretation, telehealth, an accessible clinic or dental health, everything that can be made accessible for everyone is just better for society as a whole.
All right, thank you. Next group, let's have maternity go next.
I can represent for the maternity group. This is Issei. So we talked about 3 of the accessibility sort of layers. So from the physical accessibility, we talked about things like increasing mom-to-be parking as an example, especially as patients are going to appointments, and if they happen to be going to appointments where it's a very large campus or a very busy place like downtown or something, it can be really difficult to find parking, even if you're fully bodied, abled, and it's more troublesome if you have some disabilities to consider. And so just being mindful of that physical area for patients and their visits. So even starting from places like parking, and then we also talked about exam rooms and just the whole process of getting care as a patient, and knowing like what if you need a physical exam this time and you didn't know that, and so maybe you didn't come with the being prepared, or maybe you would have had some additional like family members or someone come to support you and you didn't know that was happening, so you didn't. And so I think just that whole process would not feel very inclusive. And so those were some of the ideas that we thought about from a physical perspective. And then as we were thinking about information and communication, just going along with maybe that appointment theme, just explaining the process of appointments and explaining the timing and frequency of appointments. I think when birthing persons become pregnant, they may not know how frequently they would be going, maybe towards the end of their prenatal care, let alone during the whole process. And so just making sure people are aware of the expectation if they're seeking prenatal care, like how often and why, and just providing more explanation around that. And then additional recommendations are, how do we get information, especially for Medicaid patients who are looking for non-traditional birthing options? So if things like doula services are covered, how do we make sure that everyone knows about that so they don't actually have to go searching for those resources, and just making sure that everyone has an understanding of what's available to them if they're looking for non-traditional birthing processes. And then finally, under the cognitive and sensory accessibility, simplifying communication around maternal care so that patients can continue to advocate for themselves. And I think we talked about, getting rid of that medical jargon. And that would be especially important for this population, especially if they have some disabilities. And then if a patient has a cognitive, disabilities, was more of a question, how is that accounted for in the maternal care delivery? And how do we think about that from the beginning so that they have all the services that they need? And that is it for us.
All right, thank you. Next, let's hear from the vaccination and the COVID-19 group.
I'll go ahead and speak to that. So we had a lot of discussion about, I think some of the themes that we've had discussions about prior topics is really this idea of going to the community and meeting people where they are, and a lot of the successes that we've seen around the promotoras and the ambassadors and the vaccine buses, of being able to actually show up out in the community where people already are, to minimize that burden of transportation and other access issues. And so we know that with CDPHE that they previously had the vaccine bus and are pivoting now to having more of a van option. And I think with the focus on rural areas, so we had a lot of discussion too around access in our rural communities, which ties into, we talked a little bit about how we can hold providers more accountable, potentially by incentivizing providers to offer certain types of accessibility services, or engaging more with their communities. And then another piece that we discussed that early on in the pandemic, when vaccines first became available, a lot of the RAE organizations were able to partner with local public health agencies to offer vaccines to homebound members in their own homes. And that was very successful, I think. And so if there are opportunities to, potentially leverage lessons learned from that, and not just focused on the COVID vaccine, but potentially how we can integrate other vaccines into that as well. Anyone else from the vaccine group have anything to add to our discussion?
Thanks.
Great, that's it from us.
All right, thank you. Let's go to the behavioral health group next.
Thank you. We had a number of things that fit in all the categories, but under physical accessibility, we talked about when providers list their credentials that they also discuss their ability to provide access and what kind of access, clearing consistent guidelines for care in Colorado, increase access to telehealth, increase care and services, inpatients, outpatient, and step down for Coloradoans with overlapping disabilities. And then under financial accessibility, expand Medicaid and CHP+, increase reimbursement rates across the board, reimburse for non-traditional, non-medication, non-prescription treatment, increase accessibility to telehealth services, addressing policies on where and how individuals with overlapping disabilities receive services so that they're consistent, align policies and services for Coloradoans with overlapping disabilities. And then under information and communication accessibility, provide information regarding providers by race, ethnicity, and gender orientation to give access to Coloradoans, increase availability of case managers with lived experience, increase accessibility to telehealth services, align policies and services for Coloradoans with overlapping disabilities, and then once again, clear and consistent guidelines for care in Colorado, specifically whole person services. And then under cognitive and sensory accessibility, we talked about that when providers list their credentials, they list their capacity to provide what kind of accessibility. And then once again, increase accessibility to telehealth services. And then under government accessibilities, we talked about advocacy for current governmental policy and changes so that our Coloradoans actually understand when changes are made and what it actually means and how it impacts them. Increase accessibility to telehealth services, and then finally, increase care for Coloradoans with overlapping disabilities. And that's it.
All right, thank you so much. And to round us out is the prevention group.
I was in that group. I think we had another person leave. There was 3 of us, and we went ahead
as well, and so we can maybe piggyback off one another.
Oh, that's great. No, I'll let you take the lead if you like.
Well, we said some similar things that have already been communicated, like um, education to members about telehealth services, education around in-home services that may be available as well. There is some really practical things about medication, home delivery for medication for access to medications. In terms of, there is a lot of information in the blue section around member education, basically increasing education about telehealth services, increasing education through posters and provider offices, putting QR codes in there, on-site sign language interpreters available where members are accessing services. If you want to read some of them as well, Jeanette, we had a lot of little sticky notes. Let's say that.
Yeah, we talked about maybe offering appointment times for people who get overstimulated a lot, you know, just maybe having to ask if they would book those at low peak times. Some adaptive technology would be good. There's a little inconsistency with adaptive technology. For example, if a person has Microsoft Office, they can right click and anything on their screen would be read to them. But if they have Google, it's impossible. Like it's very difficult to use Google and have things read to you. So Microsoft is a financial issue, an accessibility issue for some people. I also brought up having additional choices for treatment like acupuncture. So some treatments may be $400, but maybe acupuncture is $50. So just having a look at some financial choices that people can make that might save the government funding as well for those treatments. And
Yeah, I think some of these are probably repeats from other departments as well, the other teams that have been talking, but let's see, improved availability of events, assistive technology devices and home modifications. I'm not sure if you repeated or you said that one, Jeanette. We have videos and waiting areas of services available through Health First Colorado running on the TV screens, just so that members are made aware of all of the different options that they may have with access to services. And of course, targeted training for providers around cultural competency and recognizing implicit bias within disparity populations. Just signs, hey, if you need help with transportation, call, you know, if you need help, call. Just lots of reminders for people to ask for help. And that, I think that we kind of covered all of the ones that we had.
I think the one of them that I really do love, and I think would bring a lot of really good, solutions, is incentivizing those who are working to improve their health behaviors. So that one would be like a win-win situation because we would reduce cost of medical and they would actually get healthier and be paid for it in some way, incentivized.
And Julie, Jalissa, I see that you said cultural validation, not cultural competency.
Yeah,
Thanks,
yes.
Yep.
No, yeah, my friend, I just wanted to explain real quick that cultural awareness and cultural competency doesn't exist in our world. Cultural awareness means that you understand that I'm a brown woman, you're aware of that. Competency, you and I will never be able to be competent ever, but we can validate the culture of the people that we're trying to serve.
Thank you for that education.
Yeah, and there's trainings about that. I developed that curriculum.
All right, anything else from prevention group that you guys wanted to share, or did you finish up?
I think that we're good.
Okay. And a thanks to everyone, because I think some great ideas came out of all the groups. Good conversations, and some good, potential solutions came out of the group. Our next piece is really our open forum sharing of information. There's one thing I do want to share, so I'm just going to put it up on the screen real fast. And I think we shared this last time, but the OMB, Office of Management and Budget, are having their race and ethnicity listening sessions scheduled for August 24th, 11 a.m. Mountain Time. And I've listed the link on there for the meeting. Again, I'll share more information as I get it. Any more details, any more information, if we're opportunity to present information or provide information, I'll share that information, but just wanted you all to have the link to the meeting for you to listen in on August 24th. And so now I'll just open it up to the group if anyone else has anything they want to share. Community announcements, any other questions that you may have on the dashboard that I can take back to Allison and get some answers for anyone. So I'll just open it up now.
So I just wanted to kind of bring some feedback that I don't work for the company anymore. I'm more of a consultant role, but right before we invested some funds into Care on Location. We built a telehealth enabled mobile van because we found that actually co-locating inside the harm reduction center still put us in the background and wasn't able to kind of promote that we were there as a clinic. Our vision is like basically, access depending on where you feel safe. So inside a harm reduction center, at a food share pickup. And so our van is actually going to Pueblo Cooperative Care's food share days and just existing in the parking lot for people to inquire and can be seen pretty quickly within about 20 minutes, probably less than that, just to build some more, honestly, trust and awareness that resources are available. We are focused on Medicaid, so obviously we're pretty much primarily do that. Oh, cool, Dan. Glad to see that you've seen us. And so, our goal is, I think there is opportunity for more organizations to do the same thing, health systems or even RAISE to actually support investment into solutions like that, where they can go to where patients are. So if there is a population that isn't being served and you want to build trust within that community, you want to help them understand or meet at least their people. And then what we found is actually, if you offer telehealth, yeah, that will be the ultimate resource probably used, but maybe you need to know that they're real, or maybe you need to know that they're trustworthy or they get you and they're not intimidated by, somebody who has multiple social determinants of health. And so we found that actually there's a slow, but very, I guess exponential acceptance of us being there, being a regular, building trust, and then, starting to kind of plan to see maybe a provider when you go pick up your food share, because you couldn't get both done in the same day, but you still need to get both in the same day. So I would challenge, a lot of these larger health systems, like we were only one tiny little company, and we were able to do that. But there's definitely reinvestment funds coming out this, fiscal period in all the ways that could support something like that or something of similar, and don't hesitate to reach out to kind of understand how to build one, because we don't want to be the only option. There's definitely enough demand to meet everybody's needs. We also started having the van at the showers that PCC has, and there was a lot of interest there. And we see at least, 2 people a day, which I think like nobody planning on seeing a medical professional. That's a decent amount of come through just at the beginning, first month or 2 of the program. So I think some of the things brought up here, I think there's validation, but I think it's going to take always time for the community to start to trust it and believe that it will stay, that it's really what it is, and that it's really meant for them.
Thank you. Anything else from anyone?
Yeah, I would like to just bring something up. CCDC has opened a new chapter in Eagle, and this last weekend I had the opportunity to represent to do a Medicaid presentation. It was a Medicaid buying / Medicaid waivers presentation in Spanish. So I would like to just say for HICPAF and for all of you to be aware of that. So if you need help with someone in Eagle, I'm happy to share contact information in there. We have 3 main leaders there, myself included, just because I do speak Spanish, and that chapter is focused on the Spanish-speaking community, which there's a lot in Eagle. It's funny, I entered a restaurant the night before the presentation, and the whole restaurant spoke Spanish, the entire staff. It's like a majority there. We are not a minority, we are a majority. Everywhere I went, even in the hotel, the clerk spoke mainly English, but spoke a little Spanish too. There were plenty of Spanish-speaking people who were local. It's incredible to see how many and how much inequity there is too. So that's why we had to open our first chapter there. And we also want to invite, of course, the Grupo Vida to help us there, because I think that will be an important connection to make for Eagle.
Thank you, Jose. Anything else from anyone?
Yeah, hey Dana, this is fun. I just recently learned about news within the broader Medicare or CMS world that I thought might be interesting to this group. It's their proposed rules for 2024, and part of the rules that captured my attention was the one to allow marriage and family therapists and mental health counselors to receive Medicare coverage for their services. And the second one was paying for services provided by community health workers and peer support specialists to address health-related social needs. So it's in the, I'm seeing a lot of head nods, and so I'm so glad that you saw that too. If any organization works with Medicare, the opportunity to submit comments to kind of push these further to be a final rule. The deadline is September the 11th of this year. So putting it out there for anyone who's interested, but was pretty excited to see those come through.
Thank you for sharing that. I did see that come through. Anyone else?
Yeah, I threw it in there, but Gravity Project in particular, I don't know if everyone knows about it, but they're actually a community built, I guess, organization where they do public consensus, but they're building out all the standardization for CMS, SNOMED codes, ICD-10 codes, and also recommending for AMA to do CPT codes on social determinants of health. I participate on all those groups, including the technical one that we did a connect-a-thon today, where we're essentially, you know, all the interoperability, the health information exchanges, all the hospital and EMR stuff. There is some framework that is being built so that when social determinants of health become an incentivized and tracked metric, that there are codes that are, you know, accessible, they're inclusive, the language is appropriate, the definitions are appropriate, and the way that it is being moved over from health information exchange to health information exchange will be, you know, responsible and actually useful in the use cases that exist for community-based organizations and for healthcare organizations. So if you have an interest in that, that is definitely a place to go, but definitely talked about digital equity a lot this month. But there's a lot of standardization that exists on, you know, how to, you know, screen for health related social needs beyond the Prepare, beyond the AHC, which I think are also a little bit more culturally validating. So just, I challenge everybody, if you're building programs for that, definitely go to Gravity Project and see what options you have, because most of the things that are being used are really not appropriate for asking these people in these populations. They're quite traumatic to answer.
Thank you.
Real quick, I know we have 5 minutes, guys. Hang in there. This is Julissa. The state of Kansas and me, Colorado, we're starting a Latinos Unidos for Vaccines Coalition. We have many Latino coalitions. They focus on diabetes, cardiovascular disease, and other chronic conditions, but this one solely will be focusing on policy and advocacy at the national level. We have 15 states so far who happen to be leading vaccine work, and they're Latinos. This group will be open later down the road for everyone, but right now, if you know anyone in any state that might want to join us and is Latino and understand vaccines, I just put all my information in the chat room, and let them know that we're going to be here fighting the good fights when it comes to access to vaccines. BFC 317s, here we come. Thank you very much.
Thank you. And I think with that, I just want to thank Jose for his presentation today. I think that was some great and valuable information you shared. So I appreciate your time in doing that. Our next meeting is scheduled for September, and I don't have the date exactly, but September. So we will all see you all in September. We'll send out notes, minutes, updates, and anything else that may be of interest to the group. We'll get emails out to you there. But I just want to thank you all for being here today, and have a wonderful rest of your day and rest of your week. Thank you.
Thank
Bye,
you.
everyone.